All right, Dr. Goldstein, Franz von Zuppe, and I are ready whenever you are.
Okay, it's about that time. Time
Let's
to
do it.
turn down the musical accompaniment. Okay, very good. Well, good morning, everybody. Welcome to Neurology Grand Rounds. I did want to remind everybody when you're calling on Zoom, to make sure you change your name to your actual name so that you can get credit and that your attendance can be recorded. We're also live streaming this on Zoom this morning, another new thing for us. Our speaker today is Dr. Tim Ainger. Dr. Ainger got his BA in psychology from the University of Tennessee, then an MS in clinical psychology from Barry University, followed by a PhD in psychology from Gallaudet University, and then a fellowship in neuropsychology at Wake Forest. He's also now known on UK Now as being an advisor for the Fox series Prodigal Son that is on Mondays at 9. So tune in and you can see his name in the credits. Today he's going to be assisted by Dr. Patricia Olson. All of our grand rounds, we try to begin with a patient example, and Dr. Olson is going to provide that. She's a PGY2 resident in neurology. So Dr. Ainger.
Good morning, everyone. I assume that everyone who's muted is saying good morning out loud. I'm just going to pretend that we're all social like that. Couple of housekeeping items before we get started. For those of you who were awake with me at 6:30 this morning and ran to your window, that was snow, not frogs, as some may have predicted. But hopefully the warm weather will return again today. So today we are going to be discussing the concept of isolation and sort of how it impacts all of us going forward as we deal with this current healthcare crisis. And we're going to talk about some things we can apply to our patients. As you may have surmised from the title that got sent around, much like my wife learned a long time ago, the jokes will be bad, but the science will be good. So we're going to try and have a little fun and learn something today as well. I will be assisted in case presentation today, as Dr. Goldstein said, by Dr. Patricia Olson. So just a few housekeeping items going forward. I have no outgoing financial disclosures pursuant to this presentation. I am not being reimbursed in any way by any isolation related or any self-help related tactics or techniques. I have only money going out, no money coming in. This is where all my money goes right here, my lawn and my children, apparently. So the goals and objectives today, I want everyone to be familiar with one or two hallmark studies that we've gotten from the field of social psychology and how they relate to isolation and well-being and sort of cognitive and neurological changes. We are going to talk about how socialization and isolation juxtaposed to it are applicable to patient care and personal care. And we're also going to talk about various well-being techniques, how we can implement them for ourselves, and how we can make recommendations to our patients going forward. On the heels of last week's presentation by Dr. Jordan Harp, I not only am thrilled to be in a part of his system now, but the other kind of reference to systems is we want to make sure that we're providing our patients with a full comprehensive systems approach to care, meaning that we want to get involved and make recommendations for them in as many aspects as possible for comprehensive healing. So the plan, like I said, we're going to dive into some social psych research. We're going to talk about how these concepts apply. We're going to explore some strategies. I don't have any additional masking or antiviral tips for you all other than this one. It seemed like to be the only logical choice given availability of PPE. But at this point, I want to turn it over briefly to Dr. Patricia Olson, who is going to give us a case presentation. The caveat being that this is a case where a number of people in our department may have become familiar with this case, but she has synthesized it for us to draw attention to some different aspects of their care and concerns than we would typically have. So Dr. Olson, take it away.
Okay, so, and I hope that you could hear me over the announcement. Forgive me, I'm in one of the classrooms. at Chandler. So this case is about a 66-year-old male with a history of hypertension. And this case is well known to a lot of the neurology residents and even some of our friends in the internal medicine department. And so this patient presented to UK on February 20th, initially as a stroke alert. He had some left-sided weakness, left facial droop, NIH stroke scale of 5. And then quickly he progressed to worsening generalized weakness and hyporeflexia. He actually was found to have severe quadriparesis, and he was even transferred to the neurology ICU. Within 24 hours of presentation, he was intubated. After infection was ruled out, the leading differential was AIDP, and he was treated with IVIG for 5 days. The laboratory studies did end up being positive for Campylobacter jejuni, and the nerve conduction studies then revealed sensorimotor neuropathy, axonal greater than demyelinating, and he was diagnosed with AMSAN, or acute motor sensory axonal neuropathy. His hospital course was complicated by MSSA pneumonia twice and with DVTs, for which he was treated with warfarin. He received a trach and a PEG, and PT-OT recommendations evolved throughout his hospital course. He initially was referred to or recommended LTAC, then he progressed to subacute, then acute, and then he kind of bounced back and forth. So the social history of this patient, so he's Spanish speaking, he lives in Mexico, and in fact, his sister is an MD in Mexico, and he does have insurance in Mexico. He's been in Lexington since December 2019. He's here on a travel visa with his wife, visiting his son and daughter-in-law and grandchildren. At baseline, he's independent in performing his activities of daily living. He ambulates with a walker just fine. But here in the US, he's currently without insurance, without a payer source. And also of note, during his hospitalization, there was a recent passing of a family member, and the family contacted the team that the patient's brother-in-law passed away. And they did not want the team to share this information, this news with the patient. They wanted him to focus on his own care and healing, and then they planned to tell him after his hospitalization. So as you can imagine, there are a great deal of isolation factors, and there are a lot of layers to this patient. First and foremost are the geographical and financial ones. So he lives in Mexico, his life's in Mexico, he has insurance in Mexico. And so it was difficult to find placement for him, to even find a place with his insurance issues that would take him. And the one that did is in Indiana. So that's the family that he does have is here in Lexington. And then even with those pre and post COVID restrictions, because again, his sister is an MD in Mexico and is currently looking for a rehab place for her in Mexico. And so they would try to figure out a way to transfer him down to Mexico so that he could be back with his family and his sister. But now with the COVID restrictions, that's not an option. And then also, as you can imagine, the language and communication barrier. It was never more startling as seeing his wife at bedside every day and seeing her. And it was interesting how much information and review of systems she could glean from her husband, who could really only nod yes or shake his head no. And I was the resident on the team, one of the residents on the team, the day before the COVID restrictions, where we had to limit visitors, and she was at bedside saying all these things. Oh, he can't hear out his right ear, all of these detailed, rich review systems. And then that was followed by the next day when she wasn't at bedside. And then I was surprised and then realized that, oh, the visitor restrictions. And there was he in an empty room, just staring at the ceiling. And so our experience was enhanced by Dr. Louie, who was one of the residents on the team who can speak Spanish fluently. And really, when he spoke with him, the team really marveled at how much just the experience was enriched by being able to not just speak Spanish, but really appreciate the micro expressions and just the little conversations and the reaction that the patient had when Dr. Louie was speaking. Often too, when I was on service, I would, of course, prefer an in-person interpreter, because the patient would try to mouth words, and that's just not possible with the teleinterpreter. As great of a resource that is, it wasn't the same. And then another interesting, I guess, difference was before and after the COVID restrictions is that the patient dearly loved and got a great deal out of music therapy. And after the COVID restrictions, that was not an option for him. I mentioned before just the review of systems that the wife was able to glean from her husband, and really the limitation of the patient nodding yes or shaking his head no. But also another startling point of him, due to his debility, he wasn't able to even speak or barely could mouth words, but also he wasn't able to press the nursing call button. And it wasn't until quite some time later that we realized that the patient was continent of bowel and bladder. He was able to use a bedpan and a urinal. It was thanks to our friends in physical therapy who noted that. But he wasn't able to call the nurse and alert him or her that he needed to use a bedpan or urinal. So unfortunately, he was often misunderstood as being incontinent when he was in fact continent, just not able to alert anybody. And finally, the isolation from his family. And that made me think a lot about how his family is going through the process of grief, mourning the loss of this patient's brother-in-law. And when I would see the patient, I would think his grief is yet pending because he doesn't have the news yet. And then, as you can imagine, just with a patient who's really, who has severe quadriparesis, who's moving along through his therapy, has physical isolation and limited moral support when he's just only really able to interact with his providers in physical therapy and then stare at the ceiling for most of the day.
Thank you, Dr. Olson. So I'm going to ask everybody to sort of think about this and then back burner it a little bit, and we're going to revisit this here in a couple minutes. But I asked the residents if anyone had any experience with cases of people who were isolated and how we could explore that. And I got a number of responses, and this was one that's going to launch us into the next thing we're going to talk about. So isolation as a concept has contributed to our understanding of neural development, cognitive development a bit, and I'm going to use one theory to sort of get us really on the launching pad here, and that's this semi-antiquated theory of the critical period hypothesis. And again, this is just one social psych theory and linguistic theory here. So the critical period hypothesis is particularly developmental, and essentially there was curiosity about whether or not there was a presence of this critical and finite period wherein one can acquire language. And at the time this was developed, the operational definition for communication was substantially more narrow than we understand them today. It was limited to verbal communication. The core flavor of this theory is that there's this finite window for first language fluency to develop, and that once a particular age is passed, that window is closed. These theorists hung their hats on this, and then this began being represented in neural development. And it is one of the theories out of which the concept of actually accent decay came from. But the ethics of research made it really difficult for people to study extreme isolation and deprivation longitudinally in a laboratory setting, until semi-recently a discovery was made. And semi-recently is a relative term, I guess semi-recently to human history. In 1970, a woman named Irene Wiley walked into a California welfare office seeking some financial assistance for herself, as she was functionally blind from cataracts and from eye trauma, and she had recently left her husband. She had in tow with her her fourth-born daughter, who drew the attention of the welfare worker, and this child was observed to be, quote unquote, a child appearing to be 5 to 7 years of age with a curious posture. And that child's name was Susan, though she is known in literature and in pop culture as Jeannie. So this is Jeannie. And some of you may be familiar with this case, so we're going to use it to sort of describe a couple of things here. There are heaps of documentation on this case. There's documentaries, legal documents, etc. Some of you may remember it from maybe an intro to psych course. I'll go over the details. There's a bit of post hoc ergo propter hoc in the history of this case, but the evidence that I'm presenting is what's generally accepted. She was, like I said, the fourth child to Irene and Clark Wiley, who was 20 years his wife's senior. His wife, Irene, had survived the Dust Bowl, but the husband had a reportedly odd relationship with his own parents, and he was repeatedly described as being overprotective, controlling, paranoid, and mentally unstable. After his own mother was accidentally killed in a hit and run with a teenage driver, he moved his entire family into his mother's home. He boarded up the windows. He established his mother's room as a shrine to his mother, and he forced everyone to sleep in the living room except for Jeannie. Jeannie had her own room. When she was observed to be between 5 and 7 years old at the welfare office, she was actually 13. She was 54 inches tall and she weighed 59 pounds. And there's a collective gasp from the pediatric core in the room. At birth, she was diagnosed with RH incompatibility, but she received a therapeutic transfusion and was otherwise healthy. However, her father's paranoia compounded, and he was determined the only way to keep her safe was to seclude her forever. Jeannie was locked in a small bedroom. She had a crib, a toilet training chair, a raincoat hanging on the wall, and a wooden board. During the day, she was shackled to the toilet chair, and at night she was placed into a straitjacket type sleeping bag, put into the crib cage, and surrounded by chicken wire. She was initially punished for attempting to verbalize as a small child to get attention, so she learned to stop vocalizing altogether. Her only auditory stimuli were the vague sounds of the bathroom against an adjoining wall and the intermittent sound of planes that would fly overhead from a nearby airport, and her father occasionally standing outside of her bedroom door and barking and growling like a dog. She was provided with some toys. So she had a raincoat, she had pages from a TV guide, empty food containers, and empty thread spools. This is Jeannie's room. This is horrific, so I want to go away from this picture as quickly as possible and get back to the pictures of the girl. But this is what Jeannie had for the better part of 13 years. So in 1970, she was rescued and put into the care and observation of a National Institute of Mental Health funded team that consisted of a child abuse expert, a social isolation expert, a linguistics PhD candidate, and a child psychologist. And what a dissertation this was for the PhD candidate. The team was charged with assessing, educating, and attempting to rehabilitate Jeannie. Their initial concern was that she was perhaps intellectually disabled because of the way that she was presenting, but they immediately ascertained that she was in no way intellectually disabled. She was just severely deprived. So we had an in vivo case study of someone who had this acute isolation and deprivation. Language tests initially indicated the only words that she understood were blue, red, green, brown, mother, walk, go, and door. And the only words she could speak were a combination of stop it and no more. So they were initially amazed at how quickly she was progressing once she was provided with such a rich environment. It was proclaimed that she would make a year of progress every few months that she was in the rehab hospital, and they ascertained that she would prove quickly the theory of critical language period incorrect. However, she plateaued and her verbal language never experienced the language explosion that we expect beyond 2 to 3 word sentences. Interestingly, though, she had a very complex grasp of visual language. She had individualized gestures for every single object that she encountered. And when provided with an education of it, she took very quickly to a version of sign language, not formal American Sign Language, but it's sort of a sign English. It was later theorized by linguists that she had passed whatever this critical period for verbal language development was, and this is compounded by trauma. And while she was completely deprived of all auditory and verbal stimuli, because she had had some visual stimuli, her ability to perceive information, she had some depth of field that developed, and her ability to use and manipulate what little toys she had in her field lent itself to a relative strength in visual language development. So the implication from this is more or less cognitive developmental, that deprivation and isolation can have a profound impact on at least one and possibly more aspects of neural skill development and neural growth. So Jeannie, by the way, at last check, the public is largely leaving her alone, but a private investigator was sent to try and find her. And a few years ago, they said that she's living in an assisted facility and she's generally happy. There's a lot more to this case, but this is not the entire purpose of this presentation. So she provided us with insight into isolation and cognitive development from critical periods from birth, but what about adults? So a significant amount of the information that we have on adults experiencing isolation comes to us from the forensic world with regard to solitary confinement and changes that individuals experience therein. There are some studies that support the use of solitary confinement, but they've been demonstrated to be almost comprehensively flawed. Their results not credible, and they need to essentially be scientifically disregarded. The forensic community basically says you need to lean on solitary confinement as a therapeutic tool only when extremely necessary, such as the greater good of people in the prison are at physical risk. In 1861, G.C. Atfield, who was the chief medical officer at Fremantle Convict Establishment in Western Australia, observed that there can be no question that separate solitary confinement acts injuriously from first to last on the health and constitution of anybody subjected to it. Haney, in 2018, posited that there are three main factors that constitute the basic makeup of solitary confinement, forensic or otherwise. Those are social isolation, reduced activity and environmental input, and a loss of autonomy and control over almost all aspects of daily life. And while these three can exist in any combination, they do represent a degree in confinement. They are a little bit subject to gradation here. So they do arise from studies on prisoners, but these criteria are in no way restricted to the prisoner population. You can experience a combination of these three factors, even if you're not a forensic patient or if you're not a prisoner. So given the impact of long-term isolation, that, like I said, the literature says it's basically a bad thing. Multiple researchers have now begun working on the concept of this isolation syndrome. So it's not a diagnostic label of any type, but it does represent a grouping of cognitive and neurological symptoms that can exist on a spectrum. So while individuals with pre-existing psychological conditions in some studies have been shown to be more vulnerable, they are in no way the exclusive sufferers of this condition. So there are individuals who have been otherwise appreciably healthy that have begun to suffer the effects of isolation syndrome. It's compounded by separation from others, as well as internal depersonalization and external depersonalization. So being the recipient of depersonalized policies and procedures, as well as taking part as a mechanism of their implementation. The physical effects that present more often than others are gastrointestinal and genitourinary problems, diaphoresis, insomnia, eyesight deterioration, lethargy, weakness, fatigue, feeling cold, heart palpitations, migraine headaches, poor appetite, weight loss, diarrhea, tremulousness, and any aggravation of pre-existing physical symptoms. The psychological effects that have shown up repeatedly are anxiety, including onset of new panic attacks, depression, emotional flattening and blunting, feelings of hopelessness, loss of impulse control, anger, rage, poor concentration, weaker attention span, weaker memory, confused thought process, disorientation, and even ranging to perceptual distortions, paranoia, psychosis, and thoughts of self-harm and suicide in otherwise healthy individuals. So thankfully, this syndrome is not irreversible. However, the reintegration of the individual back into their normal routine is another quote unquote critical period. Titrating their responsibilities and titrating socialization up is of paramount importance because low socialization during reintegration is directly linked to reportedly lower quality of life, but simultaneously you don't want to overwhelm the person with tasks and stimuli coming right out of the stupor they were previously in. This process of reintegration after being isolated is related to the process of a multidisciplinary systems approach driven rehabilitation process. And contemporary rehab facilities, by and large, take this to heart when they design adaptive rehab protocols. So one of the more contemporary examples that came to mind for me was the Rancho Los Amigos model. They have even developed their own cognitive functioning scale, which they use almost exclusively for emergence for comatose patients, but it takes into account not only neurologic functioning, but also how an individual responds to a social environment beyond just being in the bed, but also getting up and moving around and taking into factors socialization with others. So we take a page now from this information and we consider the case that was presented by Dr. Olson. We can see how any number of factors can begin to impact a patient's perception of being isolated. And in her case, exclusively, we have a patient who is really isolated in plain sight, who is very visible, very present in the hospital, but due to social restrictions, linguistic restrictions, physical restrictions, and ability to sort of generate verbalized responses, they're isolated beyond their control. So the interwoven fibers of cognition and affect can very easily negatively impact someone's rehabilitation trajectory. there may not be a greater example in an acute shift of communication ability and the person's ability to impact with the outside world in rehabilitation than the case of Jean-Dominique Bauby. And I apologize to anyone who actually speaks French. I obviously do not. But Jean-Dominique Bauby was a French journalist. He was an author, and he was at one point the editor of Elle Fashion magazine, which I promise I have never read, if you couldn't tell already. So at age 43, he suffered a major stroke and was comatose for 20 days. And upon waking, he was without speech and he was almost comprehensively paralyzed. He could only blink his left eye, and he was diagnosed with locked-in syndrome. So this quote here is directly from him in his reflection of his emergence from rehabilitation. In the past, it was known as a massive stroke and you simply died, but improved resuscitation techniques have now prolonged and refined the agony. You survive, but you survive with what is so aptly known as locked-in syndrome. But how did someone so comprehensively impaired communicate something so eloquently? Well, a linguistic specialist at the hospital noticed he was capable of blinking his left eye and that he would alter his pattern of eye blinks depending upon the situations that were around him. And she worked with him to develop what is known as a sight board. And this reference here comes from a feature film about this, but it's an incredible film and it's on HBO Go for those of us who are curious. He was able to use the number of blinks that he was soliciting to coalesce with the number of letters in order of the board. So if he wanted to say the letter R, he would blink 4 times and she would write down the letter R. And by blinking and letter by letter by letter, he was able to dictate and edit this entire novel, The Diving Bell and the Butterfly. This is the English version. There's a French version as well, which I will not be pronouncing. So he published this entire book over the course of 2 or 3 years. And what has been repeatedly observed by psycholinguists was the drastic shift from his reflection on acutely following the incident and emergence to his evolved psychological state to not necessarily quite hopeful, but definitely out of the pit of despair that he was initially in. And he was back to making his sort of sartorial, sardonic jokes. So you see, he at one point even joked, if I must drool, I may as well drool on cashmere, insisting that he be provided with finer cloth and pillows in the hospital. Sadly, 2 days after the book's publication, he succumbed to pneumonia. I promise there is some positive stuff in this presentation to you guys. But this book is a great read for anyone who really wants to experience firsthand locked-in syndrome and cognitive rehabilitation. Also, the movie is a nice watch as well. Like I said, it's available. So surely the emotional impact of isolation, depersonalization, and distancing, that's only limited to our patients, right? There's no way that anybody other than a rehab patient could experience these concerns. Yeah, right. So the argument is repeatedly being made in the media and in mental health circles that despite obviously necessary protective measures that we're all taking as clinicians, the secondary impact is depersonalization and isolation. We are all social distancing for a reason. We don't want to spread the virus, but also we are no longer interacting with our patients the way that we normally would. We're making room visits that are dependent upon the amount of PPE that we have available, and we're entering rooms, masked and gloved and gowned, or we're seeing people via telehealth, and it sets a completely different dynamic than the previous environments we're used to. We hear stories of physicians sleeping outside of their homes or isolating in other rooms of their houses to protect their family members. There's this concept of the superhero effect. It's another pitfall of our own cognition, meaning that we worry that some providers feel compelled to care for others at all costs. And if they do otherwise and sacrifice themselves, they're not doing their job well. And that's obviously not true, but it's still another psychological concern. The other concern is that the longitudinal impact of this heightened level of arousal. Heretofore, we were donning and doffing our PPE and putting these restrictive measures under duress and emergency. And now that that emergency has become a routine, there's the concern that we're psychologically putting ourselves in fight or flight as a day-to-day operation, and that's not psychologically healthy for us. There's a 2020 journal pre-proof that indicated during the peak of the 2006 study of SARS outbreak victims in China, depressive symptoms peaked at a prevalence of about 3.7% in the population. Someone did a study in December of 2019 with post-traumatic stress symptomology using a DSM-5 contemporary model and found that juxtaposed to 3.7% in SARS patients in 2006, in China at peak, post-traumatic stress was around 7% of the population. So almost double the post-traumatic stress, although I think part of that is due to a better understanding of post-traumatic stress. We've heard joke that after all this is said and done, every physician, nurse, tech is going to need PTSD therapy, but it may be something we need to prepare ourselves for. We're also at risk for moral injury. When we weigh the concept of beneficence and non-maleficence with our patients, a moral injury is operationally defined as psychological distress that results from an action or a lack of action when we violate our moral or ethical code. And thinking about the way that we provide care to patients, there is a difference between the concept of we did all we could versus we did our best with the resources that we were allocated. And this is obviously of great concern for people as we try to get through this as best we can. We're coping with working in unfamiliar settings and things that are not the norm for us. In this instance, survivor's guilt may be associated with those who are fortunate enough to work in a facility with a relatively low threshold of COVID patients or a somewhat adequate plan and supply, but having colleagues and family members and friends who are working in facilities in other states and other countries that are overwhelmed and stretched beyond their capacity. And we hear the stories that they're talking about. Are we at risk for experiencing guilt because we're lucky enough that our facility may be better prepared and we are not experiencing the threshold that they are? Communication, receiving communication from, you could even say from an international to a national to a regional to a state to a local to a department to a division to a team level. There are multiple sources where we get our information. So making sure that it is open, honest, realistic, and pragmatic. We don't want it to be sugar-coated and we don't want it to be obfuscative, but the more cooks that are in the kitchen, the more distilled the message can get and the more confused everybody can come. So this is why I think, and I'm not just trying to kiss up to Dr. Goldstein, who hopefully is winning his game of solitaire right now, but I think it's good that we have some neurology-specific communication that is catered towards us and is sort of appropriately distilling the greater messages on a daily basis. Contemporary models and recommendations for how we handle stressful situations highlight the need for preparation, continuous communication and management during the incident, and then post-incident debriefing that involves everyone involved to the extent possible. This is essentially a professional mirror image of what we do in comprehensive rehab strategies as we prepare people, make a plan, implement, and then rehabilitate afterwards. All right, so now that we've talked about all the doom and gloom, how do we take this meme on the left and turn it into this meme on the right? And how do we reset ourselves psychologically and put ourselves into a better headspace? So, like Jonas Salk, if I knew the cure for these emotional concerns, I would open source them immediately. The majority of human history is shared experience. However, human perception is highly individualized. And as we learn from the theme song from Different Strokes, the world doesn't move to the beat of just one drum, and what might be right for you might not be right for some. So there's no one singular strategy, no one singular treatment, or no one tactic that is plug and play and works for everybody. So much like the astronauts of the Apollo 13 flight crew 50 years ago today, who mitigated their in-flight problem with CO2 levels, we have to make a round peg fit into a square hole. And we have to take tactics that are available and well-published and see which works best for us. So let's discuss some self-care strategies, the science that's behind them, and how we can implement them now and how we can implement them to rehabilitate ourselves going forward. So my older daughter, in my attempt to be funny, she came into the room the other day and said, "Dad, why do you have the Beatles and poop on the same slide?" And I thought I was being clever. This is not fecal matter, it's chestnuts, because reframing is that old chestnut for psychologists. Reframing at its core is putting a Band-Aid on the dam, but it's basically you take an aspect of the bad situation and you try to find the positive and you use it to just suffer through and slough through to the next moment. So the picture we're looking at here today is we're going to reframe the entire COVID-19 outbreak and say in England, the Ministry of Public Works was finally able to repaint the infamous Abbey Road street crossing, because it was the first time in the history since Abbey Road came out that there was not traffic, foot traffic, or street traffic at this crossing. So it's been repainted for future generations. So there's our reframe today. Obviously, that's a Band-Aid solution, and that's not going to get us through. So let's talk about what self-care is. There's this theory that you can't pour from an empty vessel. So you can't give more of yourself when you are empty. Self-care is any activity that we do deliberately in order to take care of our mental, emotional, and physical health. It's a multi-pronged approach. You can't be completely devoid of one and have the other two intact. It's also a simple concept in theory, but it's something we very often overlook. What self-care is not is also very important. It's very important for an individual to know what is not beneficial to them. So if it's not something we force ourselves to do, it's not something we're mandated to do, and it's not something we don't enjoy doing. It's something that refuels us and not something that takes from us. It's not a selfish act either. It's not about just considering our needs. It's knowing what we need to do to be able to take care of ourselves and other people. We don't want to make additional patients. So where do we start? The golden rules are stick to the basics. You need to find your own rhythm and routine and something that works for you. And then you can explore additional ones and implement them and expand your processes as you go forward. It needs to be something you plan rather than something that just happens. It needs to be, like I said, an active process so you can convince yourself that you're engaging in something. You can add certain time to your calendar, certain time to your day, or certain activities to just sort of maintain some sanity. Keeping a conscious mind about what you're doing is what's important here. So it means different things to different people, but maintaining a basic checklist of what works for you and what doesn't work is very helpful to a lot of folks. You can say, you know, yoga works, this doesn't work, bicycling doesn't work, walking does work, and then very simply avoid the no activities and engage in the positive activities. Don't check your emails at night. Oh, we went backwards, sorry. Don't check your emails at night. Don't attend virtual gatherings you're not compelled to attend to. Don't answer your phone during lunch or dinner, whatever you can do to separate yourselves as best you possibly can. There's websites that you can go to and download some fun activities, like you can download your self-care bingo. This is just one humorous example we found, but you know, give yourself points for taking time out, taking a shower, whatever you did today. The science behind this though, there's 8 areas of self-care. There's physical, psychological, emotional, social, professional, environmental, spiritual, and financial. But if you look at what some of the examples are here, they're not as obvious as they seem. So spiritual self-care, for example, is not religious self-care. It's simply finding time to reflect upon yourself and refocus on your core values and make sure they're being attended to. Social is honoring commitments, but also knowing when to ask for help and spending time with others as available. So checking in with people, doing, you know, Zoom calls that are social or FaceTiming or things like that. And psychological, you know, it is okay to not be okay in this period of time. We're all under duress. And the sooner that we realize that it's okay to not be perfect, that's, you know, when we see these jokes on the internet of, if you don't come out of this 20 pounds lighter, you failed. That's ridiculous. It's perfectly fine to just get through this as best you can. So the word that gets thrown around a lot and gets confused a lot is mindfulness. It's having a bit of a renaissance in scientific literature, but not everybody appears to have this really complex understanding of what it means. In its simplest terms, it is non-judgmental attention to the present. It's not saying om to yourself and holding still. It's not trying to forget about stressful events that are going on. It's simply redirecting your conscious self to be in the moment and focus your energy on enhancing your well-being. It is not easy and it does not happen overnight, but it is a process. So there's a lot of science that has gone into this and people that have found ways to implement it. One study here looked at short-term mindfulness training. And when we say short-term, we mean they took 40 experimental and 40 control patients, and they gave them a training period and then 4 weeks of mindfulness sessions, and then reevaluated their mood scale. And what they found was anger and hostility, depression, dejection, fatigue, and tension were all significantly decreased in the experimental group, and vigor and activity was significantly increased. So there was no significant change to confusion or bewilderment. And my hypothesis is they use college students, and college students are perpetually confused and bewildered. But it's shocking to see that in a clinical trial, this was actually effective. And this kind of woo-woo concept that it had been dismissed as, there was actually some legitimate research behind it. So there were also some neurological changes that were found in a meta-analysis, and I have sent that to Dr. Goldstein for dissemination, so I don't go through them as well. But imaging studies have found areas of the brain that have significantly undergone improvement and changes subsequent to these mindfulness exercises as well. So that's available for literature after the fact. So what about people who are actually experiencing duress, not just college students? This is from a 2017 publication where 20 patient caregiver dyads, so it was 40 individuals, 20 of them were end-stage cirrhotic and hepatic encephalopathic patients, and 20 of them were their primary identified caregivers. They were allowed into the study if they were experiencing a clinically significant level of depression and anxiety with an identified low quality of life. They were given a pre-screening questionnaire examining their sleep, then their affect, the sickness impact profile, and then their caregivers were taking caregiver burden surveys as well. They were given a 4-week mindfulness-based stress reduction therapy intervention, which was a 1-hour body scan mindfulness exercise, and then a 1-hour adaptive Tai Chi meditation-driven group practice. And what they found was that after this period, there were significant reductions in almost all of the affective scores. There was an improvement in sleep quality. There was a significantly lower caregiver burden, both perceived and actual, and there was a significant improvement in quality of life for terminal patients and their caregivers. So that was a really fascinating study that looked at mindfulness as an adaptive exercise here. One of the things that has come out of the research is that we're seeing there's a benefit for when you combine some of these tactics. So when we tell people, oh, go do some yoga, it goes beyond just doing yoga. It's doing yoga and being mindful at the same time. So you're implementing a secondary exercise to help redirect and focus and be in the moment and stay positive. So focused muscle relaxation, Tai Chi and directed movement, or doing a body scan exercise, sometimes hiking or taking the dog for a walk. When I say going to the gym, rock climbing, playing golf, whatever is an activity that's currently allowed by, social isolation, what we have here on the right is an image of police cadets who, after their time in the shooting range, have engaged in mindfulness meditation and yoga. So here they are doing shavasana on the shooting range. And this has been shown to be very beneficial for police cadets as a preparatory technique, because obviously they're going to be living in a very stressful work environment as well. So preparing them with some pre-training has been shown to be beneficial on the backside. So looking at meditation, because we throw this around as well, this term is not interchangeable with mindfulness, but I feel like people say it a lot. There's a lot of research behind this. Meditation is the state of practiced mindfulness that we utilize to work towards achieving mental clarity and achieving emotional stability. A practitioner of meditation uses mindfulness. The stereotype of sitting with your hands and saying Om and being still, the postulate is that's risen out of people who have used that as a rhythmic, relaxing, and mindful recitation. But it's mirrored in such techniques as a body scan or progressive muscle relaxation, or even such techniques as leaves on a stream, which is where you take an opportunity to, in your mind, release stressful activities and let them pass you by, knowing that you'll revisit them later, but focusing on your own cognition in the moment. And that's where some of these therapeutic coloring books and therapeutic workbooks come out of. No, coloring a flower is not the therapeutic aspect of this. It's the fact that you're redirecting the negative thoughts out of your mind and you're able to be in the moment and focus mindfulness. That's what the therapeutic aspect of these things are. There's another one that's come out recently in literature, and that is the sensory deprivation concept. So the methodology behind this is called flotation rest, and rest, of course, is an acronym for restricted environmental stimulation technique. Some of the seminal studies are listed here at the bottom. We've seen changes in the experimental group in reducing stress, depression, anxiety, and pain, and an improvement in optimism and sleep quality. What the theory is behind this is you get into this float tank, and a float tank is a hypersalinized tank. So you sit on top of the water and the shell closes on top of you, and there's no light, no sound, and you're basically devoid of any sensory input whatsoever. And you float there for a predetermined amount of time. Some people say that it is as restorative as multiple hours of REM sleep. I don't have the literature behind that, but I will tell you the reason we have the Naval Special Warfare Developmental Group insignia up here is because DevGru, so SEAL teams, have purchased 7 of these devices that they keep on their deployment base, and pre and post deployment, their operators do an hour in the float tank to both center themselves and then begin rehabilitative therapy after their operations. So this consistent demonstration of reducing negative variables as well as increasing positive variables. This has been demonstrated across college populations, elite athletes, veterans, soldiers, and even medical professionals as well. And for what it's worth, I hope they hear this. I hope they send me a coupon, but I'm not affiliated with them. Lexington has at least one float tank center. It's called Source on High, and it's between High Street and Maxwell, right near Fire Station 5. So this is another proponent behind this is you are able to reduce all of your sensory input and focus exclusively on mindfulness and get rest. It works. Even aromatherapy. Now the literature is a little mixed as to whether or not it's beneficial or neutral. I'm not going to sit here and poo-poo it. I'm going to say there has been some research that has said it has had an antidepressant-like effect. We've seen changes in stress cortisol level. We've seen changes that have been observable on EEG. We've seen improvement in depression scores and improvement in anxiety. For one study that utilized diffused aromatherapy oils on a floor of nurses at the nursing station, and another study that did it isolated for medical practitioners at home. There's some hypotheses that this taps into the theory of subconscious olfactory memory. So we have a conscious stream and a subconscious stream for olfactory memory. The science on this is mixed. I've not seen anything that says it's negative, but just know that it's out there as a thing. Also, something that we're all learning about right now, time check. Ooh, we're flying through this, good. We can use technology to help us out. There's a number of apps that are available on your phone, on your iPad, on the internet. There's screenshots over here are from some of the Calm apps. The Headspace app is free to all providers with an MPI. There's meditations that are available on YouTube. These are lead mindfulness, body relaxation techniques, body scans that you can progressively work yourself through different meditations and implement them. If you want to move beyond that and start working on fitness or skill-focused approaches for your mindfulness, there's any modicum of skill-based learning techniques. You can learn to play the guitar, the piano. Some gyms are doing interactive fitness campaigns. There's down dog yoga. There's even Zumba, being in quotes because I'm not going to out them because then they'll have 47 people want to join. But I know there's at least one division who does an interactive Zoom-based dance Zumba class for both socialization and fitness. For entertainment for your own sanity, the Met, the Seattle Symphony, the Lexington Orchestra, they all have been live streaming concerts if music is something that helps you relax. There's also interactive things that we can put upon others in our family to help maintain our sanity. So if you're like me, I'm surprised we haven't had any pediatric visitors, but my children are largely correlated with whether or not I'm experiencing sanity that day or not. Beyond Zoom, we have Skype, FaceTime, Google Hangouts. We've been able to do happy hours with our friends. My cousin, 2 weekends ago, we were all supposed to be in Arizona for her wedding. That obviously got canceled, but the entire family got onto a Zoom call and we were able to participate with her. Obviously, that was as loud as 47 Greeks on a Zoom call would be, but it was good to see the family. If you need some assistance with education or you need to experience some of your own, Rick Steves has opened up what he calls his Classroom Europe, which is shortened learning videos where he travels to different cities in Europe and you can learn history. The Weird History website, or even children-focused apps. There's Go Noodle, which is a series of brief exercise and education apps for children. Or if you have YouTube for free, you can go to the Cosmic Kid Yoga page and plunk your kid down in front of 30, 45, and 60-minute yoga routines. Those are my children doing Cosmic Kid Yoga in the living room. It was like the greatest 60 minutes of my life. It's fun for the kids because the yoga follows the story of pop culture movies. So I think this is Alice in Wonderland yoga that they're doing, and they get really into it. So that's available for free if you have kids and you think they'd benefit. They seem to love it. Beyond that, there's technology that we can facilitate for assistance and that we can reach out to. So the National Association of Mental Illness has partnered with Instagram, and they are uploading on a multiple times a day basis assistance via Instagram that you can seek out to support your mental health. We obviously have our own physician support line that's open. The UK College of Medicine has medical student education psych services that's available for outreach. There's numbers listed here for physician providers, nursing staff, psychiatry clinic. You can seek telehealth through either the Harris Center or through the psychiatry clinic here. I have sent to Dr. Goldstein for dissemination a truncated list of national outreach services, including Alcoholics Anonymous, Narcotics Anonymous, mental health helplines. I'm sure someone at AT&T and someone at NSA thinks I am actively suicidal because I have called every single one of these hotlines to make sure that they are open and operating, and they are. So that's fantastic. There's also lots of services that are being disseminated via our daily email links. So don't just swipe delete the emails when they come in. There is vital information that is being included that is available for us. I do, there's just a list of some of the resources that we've included here, and I've sent some articles to Dr. Goldstein for dissemination. So we have hit 8:50 right on the button, but we're not going to get kicked out of the room. So I'm happy to take questions from everyone and discuss anything further.
Well, thanks, Tim. Yes, folks, we have about 170 or so folks online. So if you would like to ask Dr. Ainger any questions, try to do it by chat first. And when we get through those, then I'll scan looking for people who's raised their hands, and I'll try to call on you. Remember also that if you do want credit, you need to change your phone numbers and acronyms on Zoom to your real name so that we know that. Just a couple of other things just to add to what Dr. Ainger had said. In my daily updates at the bottom, I include links that are there every day. There are links to Calm and Headspace, and also links links to resources about moral distress. We also have links on our departmental homepage right at the top on wellness and support. And one of the reasons is that neurology in particular, even before all of this, it has one of the highest risks of burnout of any of the specialties. And it includes not only our faculty, but also our residents. When residencies have been ranked separately, neurology residents rank at the top of burnout. So we've been, as a department, have been very, very hopefully proactive and aggressive about addressing issues of wellness, resiliency, and burnout. One of the things that I did want to ask just to get the conversation started is how, to Dr. Ainger, is how priming the pump affects our responses in situations like this. As I just mentioned, neurology was already at the highest risk of burnout and issues related to resiliency and health. Does that pre-priming, as you said, during this almost like a pre-existing vulnerable period, if you will, does that make us more or less at risk in settings such as this?
So what it tends to do in the literature is it expounds the expression of sort of pre-existing, I don't want to use the word vulnerability, but pre-existing potential for people to express some frustration, anxiety, burnout, resiliency. So the best thing to do in those instances, the research has shown that people in high stress environments, it's highly modulated. Even if you know that you're, bomb squad techs and people who respond to those types of high risk situations, if they're provided with sufficient information at the outset and appropriate career education, then they are better prepared even when they enter a high stress career, because they've had the opportunity as their education develops to develop defense mechanisms and appropriate strategies to combat these things. So it's sort of like, as you're building the dam, you know you're going to fill it with tons of water, you reinforce it appropriately rather than just try and stick your finger in a hole after it already started to burst. So we need to make sure that we're integrating in our medical education at both the undergraduate, the graduate, and the postgraduate level, checking in, making sure that the mentors are checking in on well-being and wellness and providing strategies ongoing as we do, so that when we do hit the wall, we have well-practiced and well-rehearsed things that we can turn to, rather than try to throw strategies at somebody once they've gone beyond the last second there.
Great. One person asked whether we can disseminate some of the information and some of the slides that you used, especially the later ones. Again, the resources I put out every day, you can also go to our webpage. But in terms of the literature that Dr. Ainger cited, I send out reading materials after each one of our grand rounds that related to whatever the presentations was. Dr. Ainger sent me several papers that he referred to today. So I'll be sending those out to our usual list. If anybody else who doesn't usually attend our grand rounds would like anything, you can just email our education office and they'll be able to send it out, or you can also just email Leanne Rudd, my administrative assistant, and then we'll make sure that we get it out to you.
Dr. Anderson Mooney posted a question in the Zoom chat about how social isolation affects neuropeptide expression. So I have seen this literature from the animal kingdom in that social isolation downregulates critical neuropeptide that for the life of me, I can't remember what the long pronunciation of it is, but essentially when that neuropeptide is downregulated, it begets aggressive behavior, especially upon reemergence. So there's some literature in the animal kingdom behind that. She says also there's great research in the dementia and aging related to cognitive decline, suggesting that even perceived social isolation, and this is, thank you, Dr. Mooney, this is something that I tap into when we talk about social psychology. It's also not just the presence of a factor, but the perception that a factor is there. So perceived isolation, such as feelings of loneliness, has a very negative physical and psychological effect on people. She says those who in the aging population who have rated with ratings connected to 2.1 times greater risk of Alzheimer's dementia over time. I did not know that. That's very interesting. Thank you for bringing that up.
Very good. Any other questions? I'm just scanning the chat again. I don't see any others. And let me just see if anybody has their hand raised to say anything verbally, orally. Got a long list here I'm scanning through. Nope, nobody has their hand up, and it's just about the top of the hour. So I think you timed this quite well. Well, again, I want to thank Dr. Olson for that really to the point presentation. It was quite illustrative. And also to Dr. Ainger for volunteering to put this together on relatively short notice. There are lots of clapping icons showing up. So, and 6 new messages. Hold it. Let me just, yeah, they're all thank you, Tim. So great job. And again, if anybody who isn't on our usual mailing list after grand rounds for literature would like anything, please write us. Thanks everybody for attending today. I hope you found this helpful, and thanks again to our presenters. Have a good day.
Dr. Goldstein, I'll send you a copy of the presentation. So if you want, you can pull resources off those last couple slides.
Great, thank you.
Thank you.
Bye all.